I did.
And we are live, Senators.
Just can you touch the screen?
Is it that one or is it that one? I think you're like, oh, really? That one?
Yeah. All right. Good morning. It is Senate Health and Welfare Committee, and it is Cinco de Mayo. So let's get started. We have two bills that we're looking at. Hopefully we can finish up our work on those this morning. And Jen, I thought that we would begin with S-285, right? And then we'll move on to 353. I don't know what order it is in the agenda.
I think that's what it is on the agenda as well.
Okay, good. Okay, so we have a proposal that I have talked with the House. Ruth and I have worked with Jen and talked with others to put together a proposal that attempts to bring together both the House and the Senate S-285 recommendations and moves us closer together in both instances. So Jen, we have the marked up version. Can we go through that together?
Yes. Good morning, Jennifer Carvey, Legislative Counsel. So yes, you should have, there are a number of documents posted, I think, for S-285, and one of them should be a draft of some markup showing potential Senate Health and Welfare proposals to the version as passed by the House. And the draft you'll be looking at is draft 1.2.
Okay, so that 1.2, and it's the last S-285 document, at least on my list. Okay, great.
All right, so a minute to get there.
Got it.
Okay. So you'll see in highlight and bold or struck through the proposed changes. So again, this is using the version as passed by the House as kind of the base document and making some proposed Senate changes. That's what the markup shows. So in the first section, which is the development of the proposal for subsequent all-payer model agreement, the language as passed by the House would have the Director of Healthcare Reform in collaboration with the Green Mountain Care Board, I think yours did as well, develop a proposal for a subsequent agreement with CNMI to include Medicare and continue to include Medicare in our multi-payer alternative payment models. And there are a number of things that the Director is required to consider in developing the proposal. This would add an additional one that the Director should consider the role, if any, of accountable care organizations in Vermont's multi-payer alternative payment models going forward. So there has been some question about, does this involve ACOs? Where are the ACOs? So this would have the Director specifically considering that issue. Okay. On the next page in the list of alternative payment models to be explored, this is making some revisions to what had said geographically or regionally based global budgets for healthcare services. This would now say statewide, regional, and hospital-based global budgets for healthcare services, or a combination of them. Okay. Then on the next page, this is getting into the stakeholder involvement. And so the Director of Healthcare Reform, in collaboration with Green Mountain Care Board, must ensure that this process includes opportunities for meaningful participation by, and under the current language, it's the full continuum of healthcare and social service providers, payers, and this would add participants in the healthcare system. So this is trying to get away from, I know that people have issues with the word consumers when it relates to healthcare, and with patients, because not everybody is a patient at the time they're seeking services, or could be family members. So this is we try to go a little bit more broadly with participants in the healthcare system and other interested stakeholders. And then in subdivision B there was apparently some communication to the chair that the language as it had been written that requires the Director to seek to minimize the administrative burden of and duplicative processes for stakeholder input could be read, and I can see that this was, I don't believe the intent, could be read as suggesting that it would be burdensome to take into account stakeholder input, and I don't think that was the intent. I think the intent was to make it easy for stakeholders to provide their input. So we've changed the language to make that more explicit. It says, shall provide a simple and straightforward process to enable interested stakeholders to provide input easily. I think that was really where you were going, not suggesting that it was somehow a burden to.
So with, if I may, with regard to this piece, and I just want to make sure that we're following them. The participants in the healthcare system have ample opportunity to express their concerns, both, whether it's especially in public forums. I think it's good for people to come together and talk about these things, and I hope that that's anticipated in this.
I think you'll see more of that in the second section, which is the hospital system transformation engagement process, because this is really looking at what goes into, it's the payment models, which is less directly connected to the patient experience. So while I think it's important, and I think you have all expressed a lot of interest in stakeholders, everyone having a voice, this is all leading up to the proposal to CMMI for the subsequent all-payer model. So you've got a more robust, I think, stakeholder engagement process contemplated in kind of what does the future of the healthcare system look like in section 2.
Okay, and those participants in the healthcare system are included in that.
We'll go look at that. We'll get to that.
Yes.
Yeah.
I'm not sure we actually use that.
This is just the CMMI
term, but yes, we use a different phrase in that one. We use Vermonters who have direct experience with all aspects of Vermont's healthcare system is what we talk about in section 2. This is so not to suggest that there isn't a role for participants in this one, but I think the stakeholder process that has been mostly the topic of conversation has been more in that kind of delivery system side, the side of patient's experience more directly. All right, and then a couple more changes in this section 1. So if we look at page 4, well, I guess we need the leading language from page 3. So on page 3, line 15, we start with the Green Mountain, what the Green Mountain Care Board is doing. And this is kind of fleshing out that idea of value-based payments that was embedded in the first part of the section. And so in directing what the Green Mountain Care Board would do, this would add a new number 4 to consider the appropriate role of global budgets for Vermont hospitals, which is perhaps suggested in the idea of global payments, but can also work differently depending on how it's implemented. Then on page 5, we have a second report added. So the first is the existing one that you have required, which is that in January, the Director of Healthcare Reform and Green Mountain Care Board would each report on their activities under this section to the committees of jurisdiction, including this committee. And then it would add that by March 15th, the director would provide an update on this agency's stakeholder engagement process. So that was, I think, of particular interest to the chair and vice chair when looking at this to find out how that stakeholder engagement process was going. So you would hear more about it then, and perhaps express any concerns if you felt like the participants were not being appropriately reflected in the process. Section 2, as that came over from the House, this was a plan for an engagement process for hospital system transformation. This takes out that kind of preliminary step and has this be setting up the engagement process for hospital system transformation. So the first thing this does is to add the Director of Healthcare Reform for the Green Mountain Care Board to collaborate with in developing and conducting a data-informed, patient-focused, community-inclusive engagement process for Vermont hospitals. So again, not a plan anymore, but the process itself. And then it says that the engagement process shall include, and this is the first change, is coordination with that stakeholder engagement process to be conducted by the Director of Healthcare Reform in the section that we just looked at. So there would be some coordination of these stakeholder engagement processes. And I think there's some discretion for the Green Mountain Care Board and the Director of Healthcare Reform and what that looks like and how that makes the most sense, but not to have two isolated stakeholder engagement processes that are not kind of reflecting the work of the other. So then this is taking out, again, some of that preliminary planning for the process. So striking out that the plan, which is in the House version, would include which agency or organization would lead the engagement process. This is identifying the Green Mountain Care Board and requiring the collaboration with the Director of Healthcare Reform. It also eliminates the timeline showing the engagement process happening after the all-payer model. These would be happening fairly concurrently, or at least in coordination. And then it just puts most of the rest of the sections into kind of active, not a plan for how to hear from people, but hearing from and sharing data, information, trends, and insights with communities. That couple of the changes in lines 3 and 5 were just realizing that there were a couple of typos and what came over from the House, so that was on me, but at least I can fix them here.
Hard to believe.
So then on line 6, again, not a description of the opportunities to be provided, but providing those opportunities for meaningful participation in all stages of the engagement process. And I think, Senator Hooker, this is really what I was talking about, by employers, consumers, healthcare professionals, and healthcare providers, including primary care providers, Vermonters who have direct experience with all aspects of Vermont's healthcare system, and Vermonters who are diverse with respect to race, income, age, and disability status. I think this language actually originally came from this committee and was unchanged in the House, and is unchanged here as well. Then not describing the information to be that would be needed, but providing the data, information, and analysis necessary. And I just included the word engagement in here so that it's clear that it's the engagement process. Not how to assess the impact on other providers, but establishing ways to assess the impact. And then it would take out this requirement to provide information or to report in the plan on the amount of additional appropriations needed to support the engagement process. Additional funding is being provided in here, and they're being told to go forth and do it. And then finally, determining the amount of resources that hospitals would need to implement the transformation initiatives, not just figuring out how to figure that out.
I think that one is very important.
Yes, and I think that was something that was added specifically in the House.
It was.
There were some concerns about what hospitals, how hospitals were supposed to do any of these things without additional resources. So then we have the report, which is due in January 2023, the Green Mountain Care Board providing an update on the community engagement process established in this section. So a little bit more specific than reporting on its activities. Okay, so then we get to section 3, which is the appropriations. In the House, as you may recall, they reduced the appropriation to the Agency of Human Services from 1.4 million to 900,000, with some information that some of that additional funding could likely be made up through Medicaid, Medicaid matching funds. So, and I added language in here. So that number has not changed, but this would specify that it's to support the work of the director, both in sections 1 and 2, and specifying that that would include hiring consultants as needed to assist the director in carrying out the provisions of those sections. I think that is what they had testified, both the Green Mountain Care Board and the Agency of Human Services had testified that they anticipated hiring consultants, at least for some of it. This is just making that explicit. And then this would add back, so here's the difference, this would add back that 500,000 to the Green Mountain Care Board in subsection B, because they would be going forth with that engagement process in section 2 and not just planning for it. So it provides additional resources to them, provides 4.1 million total to the Green Mountain Care Board for the work in sections 1 and 2, again, including hiring consultants as needed to assist the board in carrying out the provisions of those sections. I think other than that was really where the meat of the changes were. And I don't believe there are actually any other changes.
You got the problem. Well, no, that's where I am in the afternoon.
Okay,
Make that something.
okay.
So that is it.
Solid waste facilities.
So the other sections are unchanged. What about effective date? Is that?
Effective date is also unchanged. Here's one here. So the appropriations take effect on July 1st. Everything else takes effect on passage. So there's no need to.
Yeah, so that has.
So it's really sections 1, 2, and 3.
Yeah. Okay, so, any questions for Jen on this or explanation? I mean, what we've done is taken the House language and then added in some of the Senate positions that have worked, are very key to us and moving forward, so. This would be then a further proposal of amendment to the House Healthcare Committee. Right, we'd have to send it over either today or tomorrow to ensure that there's time for them to act on it. And I have been in communication with Lori Houghton, who's taking the lead on this in the Senate, in the House. I think I said that to you all. So that's where we are. Any- Okay, good.
So should I prepare this as a,
I would
I think my
please.
thought would be that we would do a concur with the House proposal with a further proposal by striking out sections 1 through 3 and putting those in. So you don't need to do a strike all unless you want to, but we can just focus it in on the sections that have changes.
Yeah, I don't think we need to do a strike all because the
No.
other's pretty.
Right,
long.
I think it makes it easier if we kind of
Yeah,
narrow it to what's actually needed.
is that, so is there concurrence on the committee, that we, agreement on the committee to do that? Okay, and I know Senator Hardy's okay with it, because she helped.
Right,
She was in the process, yeah. And I'll talk with her, so that would be helpful.
Great, yes, when we're done in here this morning, I will turn this into a
Good,
Senate proposal, I'll have it edited, and then I will let you know when it is ready in case you want to try to bring it up today.
okay, so we want to turn our attention to 353. And Ken, we did get that email, and I was a little hesitant to dive back in to, but the DFR had a further suggestion. Do you know what their
I
suggestion
do
is?
not, and I think Alex has communicated with them, and perhaps you are.
Alex,
Hold on.
I suggested that we not hear further, but if DFR has some language, Alex, maybe you could reach out.
I think he has.
He has.
He has reached out.
Okay.
I'll let them know to send a written copy of any proposal that they might have.
That would be helpful, and then we can look at it. But in the meantime, can we go through 353 to understand what it is that we?
I think we have, but I'm happy to go through it again. So we have looked at both the clean version, which is 4.1, and the markup version
Yeah.
of 4.1, and the clean version. Nope.
We
Clean
look-
version is 4.1, markup version is 3.2.
Yeah.
And so,
So are we ready to look at the clean version? Does the committee want to look at the markup version?
Markup version is just the highlighting of the changes.
Yeah, that we had, that came from CFR and OPR. Which would you like to do?
Well, I got another email from Cigna this morning, still being upset. And I'd like to hear what DFR is recommending, because they seem to think they have a solution.
That, we're gonna do that as soon as we get it, but we don't
Yeah.
have it yet, so we can't look at it. She just sent an email saying she had something, but at this stage of the game, we need some definitive information. We can't, but we're testimony is like so far behind us right now. We could take testimony forever on this one. So which one would the committee prefer, the marked up version or the clean draft 4.1?
Let's go with the clean draft and see what.
Okay, let's do that, and then we'll see what questions pop up.
okay, so do you want to just do a sort of a high level review of what is
Yes,
in here?
please. And Alex, have you heard back? Thank you, Nolan. We didn't get there, but we will.
No, I have not heard back from them. I will send them a quick follow-up here.
Can you telephone, because we have the phone number? Can you call?
I can attempt that, yes.
Okay, good. Thank you. All right.
All right, so we are now looking at H353, which is an act relating to pharmacy benefit management. And we're looking at draft 4.1. So this is the clean version that so far, that incorporates all of the provisions, all the amendments you have made so far into the bill as came over from the House. Everybody there?
Yep.
Okay. Draft, section 1 is the intent section, which has not changed, but talks about the intent of the General Assembly to increase access to needed medications by making prescription drugs more affordable and accessible to Vermonters by increasing state regulation of pharmacy benefit managers, PBMs, and pharmacy benefit management, and also to stabilize and safeguard against the loss of more independent and community pharmacies. Some additional language there, kind of describing the services provided there. Section 1A is the section that you added at DFR's recommendation to direct them to monitor the cost impacts on Vermont consumers of the PBM regulation in this section of statute in 18 VSA Chapter 221, Subchapter 9, which is the one that has the most of the rest of the PBM regulation, and 8 VSA Chapter 107, which is health insurance regulation. Or health insurance provisions, and that's has some of the, for example, prescription drug coverage requirements. So DFR is to monitor the cost impacts of that regulation and recommend appropriate modifications to the laws as needed to promote healthcare affordability in this state. In section 2, we have, so this is getting into exactly that subchapter in Title 18 on PBMs. And so it's adding or revising a couple of definitions. One of them, and this has been in here throughout, in the definition of health insurer, is striking out Medicaid and any other public health assistance program. But in my conversations with the commissioner I realized that that was not sufficient to actually take Medicaid out of the scope of the language. So we have specified that in the definition of pharmacy benefit manager, that is an entity performing pharmacy benefit management, except an entity that provides those services for Vermont Medicaid. And then we have a new definition of pharmacy benefit manager affiliate, which is a pharmacy or pharmacist that directly or indirectly through one or more intermediaries is owned or controlled by or is under common ownership or control with a PBM. The next section 9472 has the required practices for PBMs with respect to health insurers and in a few cases with respect to covered persons. So that has to do with things like what information has to be or can be provided and the cost sharing amounts. So this replaces the language in the existing law about how a PBM provides its services to a health plan, replaces some language that describes some of what constitutes a fiduciary duty with a specific fiduciary duty, which is really to act in the best interests of the party on whose behalf you are acting. So it says they have a fiduciary duty to the health insurer client, includes the duty to be fair and truthful for the health insurer, to act in the health insurer's best interests and perform its duties with care, skill, prudence, and diligence. Some of the language is really just clarifying, like on page 4, where it says the PBM shall, and I've added do all of the following to be clear because it's a fairly long list, how the provisions relate to each other. And there is a provision that says information that a PBM provides to the health insurer that they designate confidential shall not be provided to the health insurer of anyone else except they can disclose it to state and federal government officials if needed. And that comes from the NAIC model language. On page 6, takes out language allowing the PBM contract to provide otherwise. So the existing law says, unless the contract provides otherwise, if the PBM gets any payment or benefit based on volume of sales of certain prescription drugs, they must pass that on in full to the health insurer. but there have been this unless the contract provides otherwise. Now this would not allow the contract to provide otherwise. There's a couple of changes in here from may not to shall not. It's not a substantive change, but I always worry that the phrase may not suggests may or may not as opposed to a straight prohibition. So that's why those are being updated. On page 7, subsection E, I know this was the cause of a lot of consternation and confusion. This is the language that says a Pbm contract with a health insurer shall not contain any provision purporting to reserve discretion to the Pbm to move a drug to a higher tier or remove a drug from its drug formulary any more frequently than 2 times per year. So this says the contract can't say it's in the Pbm's sole discretion, but a Pbm and insurer could agree to make changes more frequently, which I think you've heard from the insurers is needed as drugs and drug pricing change. Then we get to the part that affects covered persons. So Pbm shall not require a covered person purchasing a covered prescription drug to pay an amount greater than the lesser of the cost sharing amount under their health benefit plan, the maximum allowable cost for the drug, or the amount the covered person would pay if they were paying the cash price. And this is where you took out the language about after applying any discounts.
Right.
Then it specifies that any amount that a covered person pays shall be attributed toward their deductible and to the extent allowed under consistent with federal law to the annual out-of-pocket maximums under their health benefit plan. Section 9473 of the statute is the Pbm required practices with respect to pharmacies. I believe this is actually where the gag clause language comes in. So it talks about how soon or what the timing of the Pbm notifying the pharmacy of the payment or contested or denied claim. Then we have in subsection B, the new language here, that a participation contract between a Pbm and a pharmacist shall not prohibit, restrict, or penalize a pharmacy or pharmacist in any way from disclosing to any covered person any healthcare information that the pharmacy or pharmacist deems appropriate, including, and we know from our statutes that including means including but not limited to. And some of these are in existing law, but just being moved a little bit. So some of them are new. So this information that the pharmacy and pharmacist have to be allowed to provide include the nature of treatment, risks or alternatives to treatment, the availability of alternative therapies, consultations or tests, the decision of utilization reviewers or similar persons to authorize or deny services, the process that is used to authorize or deny healthcare services, or information on finance, incentives, and structures used by the health insurer. I should say finance. That was one of them.
Does the pharmacist, that almost sounds like the practice of medicine, the nature of treatment, risk, or alternatives to treatment? I mean, the pharmacist is giving you a pill. Is it within his scope of practice to say, you know, maybe you want to go next door to my brother, the acupuncturist?
No, I don't think so.
I mean, I'm just that.
What page is that on?
9.
Page 9.
So there is a fair amount of providing information that is within the scope of practice for a pharmacist. There's even the clinical pharmacy provisions that were added a number of years ago.
I mean, things like the availability of alternate therapies. That doesn't say alternate medications. Therapies to me is a much.
Treatment, the word is treatment, so very.
Well,
and then
this says
alternative.
that-
and then
no,
therapy.
Alternative therapies, it says under 2. Consultations or tests.
This is language that is consistent with OPR.
Well,
And.
I don't know that it,
I'm trying to.
I have not heard any concerns raised about it by
Yeah.
either of those. I think this may come from the NAIC model language, but I would like to check that.
Okay, that could be it. I know it came from one of the.
It's not our normal
Yeah.
phraseology.
I hear you. I see what you're saying.
See if I can find the. Yes, that does come directly from the NAIC model language.
All right.
Actually, all 5 of those come, and it should say financial incentives or structure. So I will fix that before we
Okay.
finalize this.
Yeah.
So if they have that opportunity to consult with this, that's what I didn't sound right.
It's
It needs to read
information
finance.
on finance instead of, which
It should be financial incentives and structures used by
Okay.
health insurance. So then we have the prohibitions, Pbm or other entity paying pharmacy claims shall not, and some of these are crossed out because they were moved to the previous section. So impose a copayment higher than the copayment under the plan or higher than the maximum allowable cost. So that's not going away, it's just moving. So also shall not require a pharmacy to pass through any portion of the insured's copayment. This would add or patient responsibility, because it may be a percentage or something other than a copayment to the PBM or other payer. Shall not prohibit a pharmacy or pharmacist from discussing information regarding the total cost for pharmacist services for a prescription drug. In our existing law, we already say prohibit or penalize the pharmacy or pharmacist for providing information to the insured about their cost sharing amount. Or, and again, existing law, prohibit or penalize a pharmacy or pharmacist for disclosing to the insured the cash price for a prescription drug or selling a lower cost drug to the insured if one is available. Then we have the Pbm contract. This is new with the participating pharmacist or pharmacy shall not prohibit, restrict, or limit disclosure of information to the commissioner of DFR, law enforcement, or state and federal government officials, provided that the recipient of the information represents that they have the authority to the extent provided by state or federal law to maintain proprietary information as confidential, and prior to disclosure of that confidential information, the pharmacist or pharmacy marks as confidential any document in which the information appears and requests confidential treatment, I'll get louder, for any oral communication of the information. It also says that a PBM shall not terminate a contract with or penalize a pharmacist or pharmacy due to the pharmacist or pharmacy. That was going to be short-lived. I was saying that. It's great to hear it, but but I can keep that up short-term, but not long-term. So the PBM cannot terminate a contract with it or penalize a pharmacist or pharmacy for disclosing information about PBM practices, except information determined to be a trade secret under state law or by the commissioner when disclosed in a manner other than in accordance with that confidentiality provision, or for sharing any portion of the PBM contract with the commissioner pursuant to a complaint or query about the contract's compliance with the provisions of this chapter.
Okay.
Next, we have for each drug that the PBM establishes the maximum allowable cost for, the PBM must make available, and this is existing law, in a format that is readily accessible and understandable by a pharmacist, the actual maximum allowable cost for each drug and the source they use to determine that maximum allowable cost. And then this would add, which shall not be dependent upon individual beneficiary identification or benefit stage. We have some other provisions about the maximum allowable cost. And then the requirement under existing law that the PBM respond in writing to any appealing pharmacy provider within 10 calendar days after receipt, provided that, and then there's some exception language, but the pharmacy provider shall file an appeal within 10 calendar days from the date its claim for reimbursement is adjudicated. It requires PBM to allow a dispensing pharmacy provider to appeal after that 10-day appeal period. But if the prescription claim is subject to an audit that the PBM or its agent has initiated, so that's the exception to the 10 days, For a denied appeal, the PBM has to provide the reason for the denial and identify the national drug code and a Vermont licensed wholesaler of an equivalent drug product that can be purchased by contracted pharmacies at or below the maximum allowable cost. And then if an appealing pharmacy is successful for an appeal, the PBM has to make the change in the maximum allowable cost within 30 business days after the redetermination and allow the appealing pharmacy or pharmacist to reverse and rebill that claim. Then we get into some 340B related provisions. So this is the provision of existing law that's was supposed to sunset, but is getting extended by until April 1st of 2024 by Section 7 of this bill. And this is the prohibition on a PBM requiring that a claim for a drug include a modifier or supplemental transmission or both to indicate that it is a 340B drug unless it is a Medicaid claim, or from restricting access to a pharmacy network or adjusting reimbursement rates based on a pharmacy's participation in a 340B contract pharmacy arrangement. Then we have new language saying that a PBM or other third party that reimburses a 340B covered entity for drugs that are subject to an agreement under the 340B statute shall not reimburse that covered entity for pharmacy dispensed drugs at a rate lower than that paid for the same drug to pharmacies that are not 340B covered entities, nor can the PBM assess any fee, chargeback, or other adjustment on the 340B covered entity on the basis of its participation in the 340B program. And with respect to a patient who is eligible to receive drugs that are subject to 340B pricing, PBM or other payer for the drugs shall not discriminate against the 340B covered entity in a manner that prevents or interferes with the patient's choice to get their drugs from the covered entity. It also goes on to say that a PBM shall not reimburse pharmacy or pharmacist in the state an amount less than the PBM reimburses a pharmacy benefit manager affiliate for providing the same pharmacist services. That a PBM shall not restrict, limit, or impose requirements on a licensed pharmacy in excess of those set forth by the Vermont Board of Pharmacy or other state or federal law, or withhold reimbursement for services on the basis of non-compliance with participation requirements. And finally, the PBM has to provide notice to all participating pharmacies prior to changing its drug formula. Section 3 makes some changes to another statute on pharmacy rights during an audit. So on page 15, and there's a very lengthy section in the statute, so this is making changes in a few places. So there's a right here not to have an entity. Some of this is just getting revised because of the way it was structured. And what was supposed to apply to what. So I think the changes on most of page 15 are up to line 16 are really sort of more technical in nature. But in subdivision 3, we have a new provision. If an audit is to be conducted remotely, the entity conducting the audit, so that the changes in the previous provision we're specifying that this is for an on-site audit. So now if an audit is to be conducted remotely, the entity conducting the audit must give the pharmacy at least 7 business days following the pharmacy's confirmation of receipt of the notice of the audit to respond to the audit. And the PBM shall not audit claims, or the auditor shall not audit claims that were submitted to the PBM more than 3 months before the audit or on a date earlier than that for which the pharmacy could electronically retransmit a correct claim, or audit claims that exceed 5 selected prescription claims for remote audit. Then we have some adjustments to the timing. So there is a right for the pharmacy to have the preliminary audit report delivered within, and this would shorten the time from 60 to 30 days following, and this is following the pharmacy's preliminary response rather than the conclusion of the audit. So changing some timing and both the number of days and when that clock starts. And then to have a final audit report delivered to the pharmacy within, and this would shorten from 120 to 30 days after the end of the appeals period. We have some new language with the right to have all payment data related to audited claims, including the payment amount, any direct and indirect remuneration or generic effective rate fees assessed or other financial offsets. To have the information on the date of electronic payment or check date and number, the specific contracted reimbursement basis for each claim, including its basis, such as maximum allowable cost, wholesale acquisition cost, average wholesale price, or average manufacturer price. Some of you know are all sort of some of the different ways for prescription drug pricing, and to have the respective values used to calculate each claim payment. Then we get to section 4, which we've spent a lot of time looking at. This is in the insurance statutes in Title 8. This section is the one dealing with retail pharmacies and the filling of prescriptions. So this adds a few definitions. The first is a definition of pharmacy benefit manager affiliate, which is the same definition we looked at in section 1A or section 2. Then it has that drug or prescription drug has the same meaning as prescription drug in the pharmacy statutes. That's the 26 VSA section 2022, and includes, and this goes through both some categories, so includes biological products, which are also defined in our statutes and constitute a lot of those kind of so-called specialty tier drugs, specialty drugs. Also includes medications used to treat complex chronic conditions, including medications requiring administration, infusion, or injection by a healthcare professional, medications for which the manufacturer or the FDA requires exclusive, restricted, or limited distribution, and medications with specialized handling, storage, or inventory recording requirements. Basically, it's saying when we're saying prescription drug, we mean all prescription drugs. So then we have a health insurer, and the change from and to or I think is non-substantive. It's just a more accurate way of describing a health insurer or Pbm doing business in Vermont has to allow retail pharmacists to fill prescriptions for all prescription drugs in the same manner and at the same level of reimbursement as they are filled by, and this would specify any other pharmacist or pharmacy, including a mail order pharmacy, which is what is currently addressed in the law, or a Pbm affiliate with respect to the quantity of drugs or day supply of drugs dispensed under each prescription. Then no changes in subsection C, which is existing law. And then we have new language, and this is, again, language that we've looked at recently. Health insurer or Pbm must permit a participating network pharmacy to perform all pharmacy services within the lawful scope of the profession of pharmacy as set forth in our pharmacy statutes. And that a health insurer or Pbm shall not do any of the following: shall not require a covered individual as a condition of payment or reimbursement to purchase pharmacist services, including prescription drugs, exclusively through a mail order pharmacy or a Pbm affiliate. They shall not offer or implement plan designs requiring the covered individual to use a mail order pharmacy or Pbm affiliate. Shall not order a covered individual orally or in writing, including through online messaging, to use a mail order pharmacy or a Pbm affiliate. Shall not establish network requirements that are more restrictive than or inconsistent with state or federal law, rules adopted by the Board of Pharmacy, or guidance provided by the Board of Pharmacy or by drug manufacturers that operate to limit or prohibit a pharmacist or pharmacy from dispensing or prescribing drugs. And they shall not offer or implement plan designs that increase the plan or patient costs if the covered individual chooses not to use a mail order pharmacy or a Pbm affiliate. And this prohibition includes requiring someone to pay, covered individual to pay the full cost for a prescription drug when they choose not to use a mail order pharmacy or Pbm affiliate. Then we had a health insurer, and I have a handwritten note here to add, or pharmacy benefit manager, shall not, by contract, written policy, or written procedure, require, oh, this is the brown bag, white bag, require that a pharmacy designated by the insurer or Pbm dispense a medication directly to a patient with the expectation or intention that the patient will transport it to a healthcare setting for administration by a healthcare professional, and similarly, and for the health insurer Pbm shall not require that a pharmacy designated by the insurer dispense medication directly to a healthcare setting for healthcare professional to administer to a patient.
That doesn't apply to Medicaid.
Right, and the provisions of this subsection do not apply.
Because Medicaid does all these
It
things.
does all.
Yes.
All right, then we get to section 5, which is the DFR report. And this requires DFR in consultation with interested stakeholders to consider whether PBMs should be required to be licensed. Right now they register, but they're not required to be licensed to operate in the state. Whether PBMs should be prohibited from conducting or participating in spread pricing. The cost impacts of PBM licensure and related regulatory measures in other states that have enacted such legislation. In collaboration with the Board of Pharmacy, whether any amendments to the board's rules are necessary to reflect necessary distinctions or appropriate limitations on pharmacists' scope of practice. Whether there should be a minimum dispensing fee that PBMs and insurers must pay to pharmacies and pharmacists for dispensing prescription drugs. How a pharmacy should be reimbursed for a claim if the PBM denies the claim in whole or in part, including whether the pharmacy should be allowed to submit a claim for the balance between the reimbursement and, to the insurer for the balance between the PBM's reimbursement and the pharmacy's reasonable acquisition cost plus the dispensing fee. Whether there is a problem in Vermont of pharmacies soliciting health insurance plan beneficiaries directly to market the pharmacy services, and if so, how best to address that. And then a catch-all of any other issues related to PBMs or pharmacy benefit management and its effects on Vermonters, on pharmacies and pharmacists, and on health insurance in Vermont. And that those findings and recommendations from DFR are due to this committee, the Finance Committee, and House Healthcare by January 15th. Applicability, so this says that the provisions of section 2, which is the 18 changes to the chapter on PBMs, shall apply to a contract or health plan issued, offered, renewed, re-credentialed, amended, or extended on or after the effective date of this act, including any health insurer that performs claims processing or other prescription drug or device services through a third party. And then saying that a person doing business in this state as a PBM on or before the effective date of the act, which you have moved to January 1st, 2023, would have 6 months following the effective date to come into compliance with the provisions of section 2. And we have the extension of the sunset on that provision of existing law on the PBMs and 340B entities. And finally, the January 1st, 2023 effective date.
Okay, so you had a word financial that needs to be corrected, and on page 19 to add PBMs in that sentence, number 3.
Yes, we do have an email now from DFR.
Oh, we do. And here's what I'm going to say. Oh, I haven't looked at the email yet. I don't know what's in it, but
It's fairly significant, so you may want to look at it.
Huh?
It's fairly significant, so you may want to look at it.
Oh, great.
I have also posted the email under public comments.
Well, there you go. So if it's public, so it says, then I'll read it to you.
It's posted under,
If it's posted under public comments.
all right, so we got to refresh. My concern is that this bill needs to get up onto the notice calendar.
Right. So basically, they want to move everything in section 4 into the study, not do it, and move it into section 5 study.
That's a big thing to ask us to
That's
do.
what I'm telling you.
So
But that's what it's gonna take to get my vote.
Well, Senator, let's
I mean,
not.
I have some real concerns about the impact
The
of.
VHI testimony was just so disjointed and inaccurate. I just can't believe that they would do that.
I don't believe I've seen testimony from the IHI.
But if we do that, that eliminates the brown bag, white bag. I'm not gonna get my vote for that.
Brown bag, white bag doesn't seem to be the issue. It's the licensing and the allowing all pharmacies to dispense specialty drugs. which is going to increase the cost, and that's what Medicaid does. To keep
Jen,
it from a cost.
Can you help clarify what would happen if we move all of that into a study? Huge.
So you would go back to existing law in section 4. So it would continue to require insurers and PBMs to allow pharmacists to fill prescriptions basically in a retail setting for the same level of reimbursement as they're billed by mail order. Would not address the PBM affiliate or other non-mail order pharmacies. And then it would move all of the language about allowing a participating network pharmacy to perform all pharmacy services within the lawful scope of the profession of pharmacy. So it would allow those distinctions for specialty pharmacies and non-specialty pharmacies.
This is interesting. I mean, do we allow for pharmacies to do what they're licensed to do? Or do we allow for insurance companies and PBMs to become regulators of pharmacies? That's the way it falls out for me. It just seems that
Well,
we
then
already.
take out the section at the front that says that our goal is to reduce costs. Because all the testimony is that doing this is going to increase costs.
No, but the issue is that the recommendation then would be to allow for insurance companies to regulate pharmacies.
No, they're just saying there's a special level of training or licensure you have to go through. And that's what Medicaid does, and they've told us to keep our hands off it, and we have our hands off it. But we're going to go out to the rest of us and put our hands in, and the risk is that $30,000 drug will cost $31,000. And that hurts the average consumer. I mean, this is 1% of 1.7% of the prescriptions and 51 or 53% of the cost.
Right.
It is a huge item.
It is a large. If we put it into a study, then we would have to ask DFR and to look at how Medicaid regulates.
Yeah, I think the way
Yes,
that pharmacies and insurance companies are dealing with specialty drugs. And I was also told that Medicaid does have a definition of specialty drugs.
so here's my suggestion. We got 5 minutes, we're gonna be on the floor. So we're gonna have to meet tomorrow morning on this. And in the meantime, we can talk with Jen and see what language might work. There might be some pieces of this that stay in. I'm gonna ask Jen to communicate with DFR on this one, so we get it right. It's a last minute request.
I don't know why they didn't do this when they first came in. That was the most
Hello.
controversial section of the bill,
Yes,
and they threw everything else.
I know. So let's, Jen, can you do that on our behalf? And then we'll stay connected on this and make sure that we get the language right, one way or the other, whether it's a report or whether it's go forward or a combination thereof. That's it. That work for you?
Yep.
I don't know what your schedules are tomorrow morning.
I don't either.
Or a conference.
Power committee at 8:30. We're gonna start at 9 and then we'll see how it goes.
All right.
Because we have it on our schedule. Okay, thank you all. Alex, we can go off live now. Thank you.
Taking us offline